Hello, everyone. Thanks for being with us today for this Ask the Mito Doc panel for the adult patient community. We've got a lot of docs on this panel, and we are so happy that they are sharing their time with us today. Joining us is Dr. Amel Karaa. Dr. Karaa is an assistant professor at Harvard Medical School. Also, she is the director of both the Mitochondrial Disease Program and the Lysosomal Storage Disease Program. She is a board-certified internist, and Dr. Karaa is dedicated to treating patients with complex medical conditions. Dr. Marni Falk will join us from Children's Hospital in Philadelphia. Dr. Falk is the executive director of the Mitochondrial Medicine Frontier Program there, and she has expertise in the treatment of mitochondrial disease, clinical genetics, and translational research. Joining us as well is Dr. Bruce Cohen. Dr. Cohen is a pediatric neurologist at Akron Children's Hospital. He's also director of the Neurodevelopment Science Center, interim vice president and medical director of the Rebecca D. Considine Research Institute, and chairman of the American Academy of Neurology Advocacy Committee. From Texas, Dr. Kay Koenig joins us today. Dr. Koenig, based at UT Health McGovern Medical School. She is an endowed chair of the mitochondrial medicine and director of the University of Texas Mitochondrial Center of Excellence. In New York is Dr. Michio Hirano, who is at Columbia University Irving Medical Center in New York City. Dr. Hirano is the chief of the Neuromuscular Division, director of the CUIMC Muscular Dystrophy Association Clinic, and director of the H. Houston Merritt Center for Neuromuscular Disorders. And rounding out our panel today is Dr. Mark Tarnopolsky, who joins us from McMaster University in Hamilton, Ontario, Canada. Dr. Tarnopolsky is a professor and division head of neuromuscular and neurometabolic disorders, focusing his practice in the area of mitochondrial disease, muscle disorders, and other neurometabolic disorders. Now, before we begin, understand that Ask the Mito Doc is not a substitute for professional advice or services provided by your own personal physician. Information provided today should be used as a conversation starter with your own personal physician. Panel, thank you for being with us today. I've got many great questions submitted for your consideration and thoughts, and I've broken them down into a few topic areas. So let's get started with some diagnostic questions. And for that, Dr. Karaa, I'm coming to you. One of the questions we get a lot is, what is the difference between primary and secondary mitochondrial disease?
Thank you, Cliff, for that question. That is an important question. So before I answer it, we have to understand what genes are. So we all have different sets of genes that we are born with. We inherit them from our father and mother. And science has shown that several of these genes are directly implicated in when they become defective in patient developing mitochondrial disease. And so what we mean by a primary mitochondrial diseases are defects in those genes that have been directly linked to mitochondria and the normal function of mitochondria. Whereas secondary mitochondrial disorders are anything that can affect the mitochondria that do not directly pertain to those genes and that guide how mitochondria function properly. So those secondary issues could be genetically related. So there are other genes that do not affect the mitochondria directly, but might affect the biology of a person that will, in a secondary fashion, affect the mitochondria. There are also other environmental factors, toxins, many different things, and other more common and chronic disorders that can affect the mitochondria in a secondary fashion. So the difference is that the primary disorders are the ones that you are born with that involve genes that directly pertain to mitochondrial normal function, and secondary mitochondrial dysfunction are those that affect the mitochondria but outside from those genes.
So Dr. Cohen, I want to ask you this question because we get it a lot in advocacy, especially in drafting some legislation. Is there a difference between mitochondrial disease and mitochondrial dysfunction?
I would say mitochondrial disease happens on the level of the human, on the person. So if someone has the I'm just going to give an example coming off my talk. If someone has the typical MELAS mutation, the the AG transition in the transfer RNA, it's 3243 allele, and has the clinical symptoms of high frequency hearing loss and diabetes and skeletal myopathy, they would have a mitochondrial disease that we would call the phenotype being MELAS. Mitochondrial dysfunction is what happens at the laboratory level of if their mitochondria are able to put out the requisite amount of ATP under the right situation, or may, because they're not functioning properly, put out too many free radicals. So I think that's probably the most simplistic way to answer that question. Certainly, people with mitochondrial disease have mitochondrial dysfunction, but the reverse isn't always true.
So, Dr. Hirano, with many options out there, in your opinion, what's the best way to obtain a clear diagnosis?
Okay, so some of your words were muffled there. So I think the question was about the best diagnostic approach to mitochondrial disease. And I think nowadays with the next generation sequencing, Bruce Cohen mentioned in prior talk, that has become the first line of diagnostic testing because it's less invasive and, as Dr. Cohen pointed out, less costly than a muscle biopsy. So we generally proceed with genetic testing depending on the inheritance or parent inheritance pattern. If there's a hint of maternal inheritance, we'll sequence mitochondrial DNA. It looks like it's recessive or dominant. We'll sequence nuclear DNA and reserve the muscle biopsy because we need to do functional analysis to prove whether any variants are pathogenic.
Okay. Dr. Falk, I want to come to you with a question. With genetic testing, can cases that are listed as probable get officially diagnosed?
Good morning, Cliff. Can you hear me?
Yes.
Okay, terrific. So that's a straightforward yet complex question. The diagnosis of mitochondrial disease historically was grouped into definite, probable, possible, or unlikely. And that goes back decades before really all that we know now about the different causes were known. The Mitochondrial Medicine Society and a lot of our international colleagues have decided that there's really a better way to think about the categories, and that's as definite. That's when you figure out the genetic and the biochemistry and it all meshes and merges. Or unlikely, where you've completed the testing and there's really no evidence and the suspicion is not high, or another diagnosis is found. And in between, probable and possible have really merged into a category we call suspected. And that's to prevent the diagnostic odyssey of forever, where you linger, but it's really unclear. And so for suspected diagnosis, there really are very clear steps that we can take. And every year, something like at least 20 novel nuclear gene diseases are identified. So of course, there's never been more capacity and therefore reason to hope that suspected mitochondrial disease, if it really is suspected based upon the clinical presentation, the laboratory findings that might be consistent with mitochondrial features, the phenotyping of the heart, the eyes, the hearing, the different organs, that we will look harder and find new diseases. Still, it's possible that people have new manifestations we haven't seen before, such as with the immune system or other systems that we're not as comfortable with based upon historic features. And I think those have been harder to figure out, but I would say the answer is yes. If somebody has truly suspected mitochondrial disease, the research and the clinic often go back and forth and work together to try and find the answer. And the group on this panel and many of our colleagues around the world are really committed to that, moving people with suspected disease forward. We also recognize that you can very much have a mitochondrial disease that is not genetic. And so for that purpose, we sometimes see medications do it. And we know that even though it's not a genetic cause, it's very real. And so we still want to help those people. Cliff, you're muted.
Cliff, you're on mute.
Okay, so a patient is asking Dr. Koenig that they had a muscle biopsy previously. Would there be a benefit after having that muscle biopsy in getting whole exome testing?
Yeah, that's a great question. So historically, the primary way mitochondrial disease was diagnosed was through muscle biopsy. So especially adults, we follow a lot of patients who were diagnosed based on a muscle biopsy. And we've moved more and more away from muscle biopsy as the first line testing and more towards genetics as the first line testing. And so these days, if you go and see a mitochondrial specialist with a suspected mitochondrial disease, a lot of times you will get genetic testing first. And a lot of patients won't even get a muscle biopsy unless they need some sort of confirmatory testing. And so it comes to the question of the people who were diagnosed on a muscle biopsy. They know they have a mitochondrial disease, and so at what point should they get genetic testing? And the simple answer is they should. There's a lot of reasons to have genetic testing. The simplest reason that I tell my patients is that most clinical trials are not going to be open to patients who are not genetically confirmed. Another reason to have that testing done is so that you have a better understanding of your mitochondrial disease. Your physicians have a better understanding of the etiology of it, what's causing it, what the pathogenic mechanisms are, and so it can help tailor therapy for you specifically. And lastly, it helps your family. It helps your family understand what their risk is, what the risk is to children and other family members. So there's lots of reasons why you should have that genetic testing done. And I would definitely suggest talking to a geneticist or a genetic counselor about having that testing performed.
Dr. Tarnopolsky, a lot of,
could I add
Sure.
to that just a
Absolutely.
bit? So I would absolutely agree that it's important to get a definitive diagnosis, but genetic testing is not always genetic testing. It depends on who's delivering it and who's interpreting it. And we have innumerable patients in whom a genetic diagnosis was given by someone who perhaps shouldn't be giving that diagnosis, and a variant of uncertain significance was found. And that was then ascribed to that person as the cause of their disease. And they carried that with them. And when we saw them, it was very clear that they had an alternative diagnosis. And it's critically important to first take a proper history, proper examination, do the biochemical testing to interpret everything together in the context of that genetic testing to firmly establish or refute the diagnosis. Because many people that we're seeing who are labeled as complex 1 deficiency, for example, have an alternative diagnosis. And that has huge implications for treatment. It has huge implications for genetic counseling and for even therapeutic interventions in the future. We've seen myotonic dystrophy, and Bruce has had a case. We've seen facioscapulohumeral dystrophy. The inheritance, the treatment, the outcome, everything is far different. So it's really important to see someone like the individuals who are here on this screen who have the experience in genetics, neurology, combining those two together to come up with an accurate diagnosis and not to miss alternative diagnoses, which can mimic mitochondrial disease. In fact, myotonic dystrophy, we are just working on a whole exome sequencing study and RNA sequencing. And one of the biggest differences between myotonic dystrophy patients and sedentary individuals is mitochondrial dysfunction, a classic example of a secondary mitochondrial disease. And if you don't look at the person in the whole context of this history and physical examination and other testing, you can miss a diagnosis. So I just wanted to put that caveat out there as well.
So I want to stay with you for the next question. You talk about diagnosis, but what do you think the percentage is for patients who are still undiagnosed?
The percentage that they have a mitochondrial disease?
Yeah, but they are not diagnosed.
Yeah, I think one needs to think about a number of things. And that's where, again, I know I'm getting old and old-fashioned, but history, physical examination, biochemical tests still are the mainstay of our diagnosis. And from there, then we choose our testing, molecular or otherwise, to rule in or rule out a diagnosis. And our goal is to find what is the cause of this person's symptoms. Is it a genetic disorder? Is it an acquired disorder? And simple things like even severe vitamin D deficiency can make you look like you have a myopathy. So it's important to keep an open mind and to search for the appropriate diagnostic. test and diagnosis. And so therefore, when you see a patient, we're not looking at, does this person have mitochondrial disease or not, but what is the diagnosis for this patient? And keep an open mind when you're going through, because as we pointed out, many things can look like mitochondrial disease, which aren't primary mitochondrial disease.
So Dr. Falk, one of our patients has asked, can you explain what variance of unknown significance means?
Absolutely. Sorry, I was muted again. Yeah, so that's a really confusing concept. So when we think about our genetic information, we have altogether about 6 billion letters of information in every single one of our cells, 2 copies of the nuclear chromosomes, one from our mom, one from our dad. Altogether, quite a lot of variance can be seen. Among those nuclear genes, nuclear genetic information, we have about 20,000 pairs of genes. It's only about 5% of the genetic information. And within those 20,000 pairs of genes, you and I differ. All of us differ. Not a lot. We're about 99+% similar, but we have variations between us. And the estimate is something like 150,000 variants between any one person and another in their 20,000 pairs of genes. So clearly not all of those variants that make you or I different from one another cause disease. So most variants are of uncertain significance. They're not related to any medical issue or really any issue at all that we're aware of. There's just very natural variation. So what we do when we look at genetic information in the nuclear genome or in the mitochondrial DNA, which is another 16,569 letters to be exact, we find variants. The variants in the mitochondrial DNA relate to the time, as our colleague Dr. Wallace discovered, since any 2 people shared a common mother. So we have variation because we've evolved from each other and we're different. And so when the genetics community has tried to understand how much of these are related to human disease, they group them into one of 5 bins. Definite, or meaning pathogenic, this variant is causing a disease. Likely pathogenic, here's the list of evidence. We are not 100% conclusive, but the weight of evidence is that this variant is related to that constellation of medical problems. Variant of uncertain significance, or VUS. And then we move over to the benign. We're not totally sure, but we think it's likely benign or it's definitely benign. So these 5 bins are really the guiding principles for variant classification in the international genomics community. So how can a variant of uncertain significance move in either direction towards benign or pathogenic? It depends on the knowledge of the community, what's been published, what's known about that variant in that family and how it segregates. Do other people in the family who have the symptoms have the variant? Do other people around the world who aren't related have that variant and have the same symptoms? Has anything been done in the animal models to make us think that that variant, when you create it or when you rescue it using genetic technologies, that it goes away, that the symptoms get better? So that's what we spend a lot of time doing as a community. As a matter of fact, many of us, if not all of us on this call, have been involved in an international effort to curate all the genes that cause mitochondrial disease and assess the level of certainty that we have. That, for example, for Lee syndrome, that any one gene or variant in that gene can cause the problem versus just being there and being unrelated, sort of being a red herring. And now we're hoping to move forward in the future and do the same thing for all primary mitochondrial diseases. So we're an ambitious community because there's a lot of genes. There's over 300 different genes already that are known to cause mito disease in different ways in different people and different variants as well. And sometimes the variant, especially for mitochondrial disease in mitochondrial DNA, it depends on whether it causes a problem based on how much of it you have, right? Because you could have heteroplasmy, some of it, a little of it, more of it, different tissues, and in certain backgrounds, right? If you're from, a European background or an Asian background, it might affect your energy differently. So a long way of saying that variants of uncertain significance are the norm. Most variants, we don't know what they do, but over time, we become more and more clear as the community works together that a given variant can cause a disease or be innocent.
So we have a lot of questions on diagnosis, and I do understand that some of the questions are being answered in the chat as they come in. So if there aren't questions that aren't answered, we will ask them, but let's move on to some questions about treatment. And Dr. Karaa, I want to go with you on this one. Huge scope of mitochondrial diseases. Are treatments one size fits all, or do treatments need to be tailored to the specific patient?
Yes, good question. The answer is yes and no. And so when we think about mitochondrial diseases as a group, every mitochondrial disease patient is going to be affected as a whole. And so there are some measures that we need to take for the whole patient because they do have a specific disease, which is the mitochondrial disease. But then every patient, depending on the gene that is affected, is going to have specific organs that are involved or specific system in their body that are involved. So this could be the brain, the muscle, the kidneys, the heart, or a variety and a combination of all of the above. And so we also have to take care of these specific organs individually. And so for the first part, for treating the mitochondrial disease patient as a whole, it's really one recipe for all. Everyone needs to be on a good nutritional regimen, good hydration. We recommend exercise for all. Of course, these regimens are going to differ in intensity and composition depending on the functional level of the patient, but we would recommend for everyone to eat healthy, to keep themselves well hydrated, and to try to exercise as much as they can. Now, for every patient, the tailored approach is going to affect the specific organs that are involved. So if you have heart disease, you are going to be referred to a heart doctor to really treat the heart problem specifically. Same thing for your kidneys, your brain, whether you have seizure disorder or a stroke, there is a subspecialist for every single symptom pretty much that you have, and that needs to be really tailored to the specific patient and the specific mitochondrial disease. And so then there is this concept of how do we try to limit the progression of the mitochondrial disease as a whole? How do we limit the severity of some of these symptoms? And unfortunately, we still don't have that magic pill and that cure. And so we turn to some supplements that some of us do recommend for our patients. So those are also, and some of them are one size fits all, where the Mitochondrial Medicine Society does recommend certain specific supplements, including the ubiquinol, the riboflavin or vitamin B2, the alpha lipoic acid, which is an antioxidant. But again, here also it depends on what specific disease you have, because there are certain supplements that are only prescribed to certain subtypes of diseases. One example is the biotin deficiencies, where we do prescribe biotin. If someone has a pyruvate dehydrogenase deficiency, we could prescribe thiamine. For patients who have MELAS and strokes, we might give extra arginine, citrulline, and other supplements like that. And so these are this is the way I try to think about my patients. So there's the mitochondrial disease overall management, which includes the supplements that can be tailored depending on the specific disease. And then there's organ-specific management that is really specific to each patient.
Just one addition.
I'm sorry, go ahead, Dr. Tarnopolsky.
If I could just add one thing to that, that is the same for mitochondrial disease as it is for every muscle disorder, and that is, don't forget the common things. So we've found 13% of our muscle disease patients are deficient in vitamin D, severely deficient at the rickets range. 11% of all of our patients across mitochondrial and muscle disease are deficient in vitamin B12. And vitamin B12 can just cause major issues with the nervous system, from neuropathy to spasticity. And so don't forget the small things. And so we usually check for B12 deficiency, folate deficiency, vitamin D deficiency, and replace those things. And also things like diabetes. We know that mitochondrial disease, such as MELAS, massively increases the risk of diabetes, but diabetes also damages the mitochondria, and it can provide a positive feedback cycle. So again, attention to the small details and looking for the common things is something that we always advise as well.
Can I hop in on that?
Absolutely.
One other issue is, especially in adults, primary sleep disturbances, obstructive sleep apnea or mixed sleep apnea, but primarily obstructive sleep apnea is extremely common in my adult patients with mitochondrial disease. It's very easy to get to a diagnosis. A routine sleep study, like everyone who has symptoms of sleep disturbances should get. And the ravages of mitochondrial disease mimic the ravages of sleep apnea. It's one thing to diagnose it, it's another thing to treat it. And the treatment for some is very easy. That same treatment for others, which is, the BiPAP machine, is very difficult. But unless you treat it, you're not going to get on top of the exhaustion that occurs in people with primary sleep apnea. So just, piling onto the list of what Dr. Tarnopolsky said. Last summer was asked to see a athlete who was at really the top of her career, a finalist at state competition for muscle pain and weakness. And she had a Ricketts level vitamin D level. Within a month of starting vitamin D, we're talking about a therapy that costs a penny a day. She was back in competition, and to this date is competing. So can't miss the simple stuff.
Yeah, that's a good point, Bruce, because there's clear evidence now that messing up sleep cycles interferes with something called the clock genes, which are directly linked to mitochondrial biogenesis. And so if you take Drosophila, which is a little fruit fly, and you mess up their day-night cycle, they start to get mitochondrial dysfunction through these dysregulation of clock genes. So it's such an important point, because most people who have chronic fatigue and are trashed, or as Bruce was pointing out, someone who's fit and healthy, and all of a sudden things are falling off the rails. Sleep study is a very important part if all those other deficiencies are taken care of.
And Cliff, if I could just make one more comment.
Sure.
Yeah, so I agree with everything Bruce and Mark were saying. The other things that I would just caution people to be very careful to look for that also exacerbate mitochondrial disease or mimic it and can be treated are iron deficiency. We've seen quite a lot of people with iron deficiency, either with or without anemia, and that is really exhausting but very treatable in different ways. Nutritional issues, like Dr. Karaa said, and also hormonal issues. We have quite a lot of people with thyroid dysfunction, adrenal dysfunction, a range of different hormonal problems that it's really important to identify and treat. So again, I think this is why Dr. Tarnopolsky's point is so well taken. The goal is to understand why people aren't feeling well, not to give them an answer that doesn't help them, but to find all the answers that might.
And I just want to make a comment real quick too, because one thing I've noticed coming to the symposium over the years is that a lot of patients who come and ask me questions come because they don't have access to a mitochondrial specialist. So a lot of us provide as much information as we can, but Mitochondrial Medicine Society has developed a website with a lot of resources on it that has a lot of this information. And there are papers there, there's recommendations there that you can take back to even your primary care doctor that lists all of this. Check your hormones, get a sleep study, this kind of basic general information, so that if you don't have access to a mitochondrial specialist, even if you just get some of those resources off the Mitochondrial Medicine Society website, you can take that back to your doctor, and then they know what to test for to try to help you feel better.
And I want to stay with you, Dr. Koenig, because we're talking about all these tests and labs. So what types of tests, what types of labs should an adult patient be asking their doc for?
Yeah, and I'm going to follow that up by saying the exact opposite of what I just said, which is there's certainly some generalities, which again, the MMS has published some great recommendations about if you have a mitochondrial disease, you should be screening for sleep disorders, you should be screening for heart disease, you should be screening for endocrine disorders. And there's, again, a great publication. So if you do not have access to a mitochondrial specialist, if you go to the MMS website, you can access that publication and you can take that to your primary care doctor, who then has that information and knows what to do. I send a lot of my patients home with that publication who come to see me just as a consult. But it often, the contra to that is it often is very disease specific. So if we know exactly what your disorder is, then it will alter those recommendations. There are certain mitochondrial diseases that put you at higher risk for certain conditions. For example, people with Paul G spectrum disorder are at risk for epilepsy, again, depending on their age range, but we may be more inclined to order EEGs in them on a more regular basis because of that. There are certain people who are at higher risk for heart disease, and so we may do more frequent cardiac monitoring in them. And so for those reasons, those are reasons to see a mitochondrial specialist who is better able to kind of tailor those recommendations. In general, I say you need to pan screen a patient every 1 to 2 years. You need to check all of their organ systems and make sure that everything is functioning. Heart, kidneys, pancreas, liver, and then in between for anything that is causing a problem.
So even if you're not having symptoms, you should see possibly a cardiologist or a pulmonologist.
Yes. Yeah. One of the things that a lot of my patients don't recognize is that the muscles, we have a lot of patients that have muscle symptoms.
Mm-hmm.
Muscles include your heart and it includes your chest wall. So a lot of patients with muscle symptoms can have heart disease that is not symptomatic. But if we know about it, then we're able to provide medications to help support the cardiac function and prolong the longevity of heart function. They also can have chest wall weakness, which can lead to things like sleep apnea and can cause hypoventilation or a decreased ability to breathe deeply, which is treatable and can actually improve their day-to-day life.
So while we're on this topic, I want to take a question that I see in the chat. And once diagnosed, Dr. Cohen, I want to ask you this. Is there a benefit to seeing a mitochondrial specialist versus any given neurologist?
I think that really depends on, the neurologist, and that's going to be a real individual question.
Okay.
And very practice dependent. If you get diagnosed, for example, if you're in an ataxia clinic and you're seeing a neurologist that specializes in ataxia, if let's say they hit it right and they do an exome and they find that there's pol G disease going on, well, if that neurologist has no experience with pol G disease, I think there's a real benefit of consulting with a mitochondrial expert to help firm up the diagnosis and treatment plan over time. That can be handed back to the neurologist, and if they're willing to go through that process, then you're getting proper care. I find in my practice, which largely the patients live outside the Akron area because Akron is a city of 100,000 people, I tend to be a consultant to primary care doctors, many of which are very interested in helping with the management program, and that I see the patient once a year or maybe twice a year, and everything else happens within the context of their primary care physician or sometimes referring neurologist. So I think it's very dependent on the particular patient, the particular disease, and the treating. And the question came as neurologist, but it could be a cardiologist, family practice doctor, et cetera.
Cliff, can I make a comment?
Absolutely.
Yeah, so I think what Bruce said is spot on. The only other thing I would say is that I think this is really a team approach, right? None of us really do this alone. Mitochondrial disease affects many organs, and you need both local specialists and sometimes people more accessible, nationally, either through telemedicine or through traveling. The idea is that, management's changing. And so getting to the diagnosis is one step. And sometimes that happens now in weeks as opposed to decades, which is pretty awesome. But we are also learning a lot from and with our patients. And so there's a lot of interplay between clinical care and clinical research, and then learning, and then precision trials and clinical trials. So there's really, I'm sure we'll talk more about this. There's a lot of reasons to stay connected to a mitochondrial specialist who's aware of all the emerging therapies, either for limited care where we know of therapies that work for a specific disease, or broader trials that are coming. And this is only accelerating, month by month now, more and more is becoming available. So it definitely is worthwhile, if you have a local team that takes great care of you, to also consider seeing a mito specialist if they're not involved, to help you get these benefits.
Can I just make a quick comment? Working in New York, I would say that more than half of the referrals I get are from other neurologists who are somewhat familiar with mitochondrial disease, but really want to be sure that they're not missing something. So I think general neurologists are terrific and often make the diagnosis, but they may not be, as Marni was saying, comfortable or familiar with what's up to, what the latest that's going on in trials and so on with mitochondrial disease. So I think as both Bruce and Marni were alluding to, I think we as mitochondrial specialists can work with the neurologists and other specialists as a team and really provide a little bit more expertise or a significant amount of more expertise.
Dr. Hirano, I want to stay with you for the next question. Patients asking, what are your recommendations for patients, mitochondrial disease patients who may have cancer? Does that impact their treatment for mito?
Yes, so it's a very difficult question to answer in generalities, but I would say that, of course, mitochondrial disease patients have multiple symptoms, multiple problems, and many of these problems overlap with the toxicity of some of the therapies for cancers. So, for example, patients with mitochondrial disease frequently have peripheral neuropathy, and that's one of the most common side effects of chemotherapies, peripheral neuropathy. So the combination can be very serious and debilitating. So I think that it's important for people who have cancer and mitochondrial disease to work together with the cancer specialist and the mitochondrial specialist, and the two negotiate about the specific therapies. And to give an example, one of the drugs that's frequently used is adriamycin or doxorubicin, which is particularly toxic to the mitochondria and to the heart. So if a patient has a mitochondrial disease, cardiomyopathy, and they're considering doxorubicin as a therapy, they ought to negotiate this and perhaps avoid that and use a substitute medication.
Dr. Tarnopolsky, we talked a little bit about this previously. It was raised, but I want to get your thoughts on it. Hormone therapy as a treatment for patients. What are your thoughts on that?
We've published papers in muscle disease patients who are older, men who have low testosterone. And with what's called hypogonadism, we know that from normal aging studies, people who are hypogonadal have low muscle mass, low muscle strength, and bringing them back to a normal level, so make what we call testosterone levels, does improve their strength. What seems to have failed, however, is in the Muscular Dystrophy Society in particular, when we gave hormones like testosterone to go to a very high level, sort of like what the bodybuilders are using, that did not seem to help patients with Duchenne or myotonic dystrophy. And I really doubt it's going to do anything for patients with mitochondrial disease, and could be toxic. We know that if you take high levels of testosterone, for example, it can cause a bleeding problem in the liver called peliosis. And that's definitely something to be worried about with mitochondrial disease, especially if you have a POLG gene mutation, for example, and you have liver dysfunction. So I would say that replacement of a deficiency makes good biological and clinical sense, but super compensating someone who's already in a sufficient level is rarely of benefit, with the exception of some of the supplements that we use for bypass strategies or antioxidants in mitochondrial patients. Now, the real controversy comes in women around the perimenopausal period, because it seems to be a second bump of a risk factor for those with Leber hereditary optic neuropathy. And everyone laughed at me 30 years ago when I suggested that estrogen was probably the reason why women don't tend to get blindness as much as men with Leber's, but work out of Italy has proven that that's actually the case. And so we generally recommend that in the perimenopausal period, in consultation with an obstetrician gynecologist, that provision of low-level estrogen, if it is deemed safe and appropriate by the endocrinologist or gynecologist, is prudent in that perimenopausal period. Also, usually with some vitamin E in the specific case of Leber's. But it's really important if one's replacing those hormones to do so in consultation with a endocrinologist or an obstetrician gynecologist. And then finally, of course, logical things like hormone, testosterone, for example, that Marni pointed out. Hypothyroidism, it causes both a myopathy, and we've had CKs of 4,000. The normal should be around 200 in people with hypothyroidism. And there's very good work out of Dave Hood's lab and others showing that low thyroid also causes very severe secondary mitochondrial dysfunction. So it's critical, if someone is hypothyroid, which is quite a common disorder, to maintain euthyroid levels. That's a really important thing to stick with your family doctor, make sure it's carefully monitored. Yeah.
And I want to stay with you because there's a question about niacin as a treatment for myopathy, and I'm curious your thoughts on that.
Yeah, I mean, there's, and Marni would be better posed to discuss this at the research level, because I know she's done a lot of work in this area. And, there is quite a bit of work on niacin and its derivatives. There's the niacin riboside and various other forms of niacin. And there's some interesting work with what's called NAR, and some companies have sprung up selling NAR. It looked interesting in animal models, but some of the clinical trials coming out of it was in Denmark, really didn't show the benefits in human clinical trials that the animal studies were suggesting. So again, I think with everything, it's important to consult with your specialist, to start with low doses, and to take things only that have good evidence of human efficacy and safety in humans. But Marni, I think, can speak more to that, because she's done a lot of work in preclinical models with the niacin.
Yeah, I think niacin's a fascinating topic. Again, we can talk about it for quite some time, and there's a huge market in the natural products for just general aging and staying on things like nicotinamide riboside and whether it's good for everybody. I think it's a different question than almost treating it like a hormone that's deficient in mitochondrial disease, which is more the case. So NAD is a really important molecule in our body, nicotinamide adenine dinucleotide, that comes in different forms, activated and inactivated. And the mitochondria, the respiratory chain, has 5 complexes. The first complex is nicotinamide adenine dinucleotide dehydrogenase, meaning NAD dehydrogenase. And that basically is complex 1. So we particularly worry about NAD levels being off in people whose complex 1 doesn't work, because the enzyme function of that complex is to make NAD. And so we think a lot about how to replace that, almost like a hormone, because it's needed for so many other parts of our body to work, parts of our cell. And so we're not sure the right version of it. We sometimes give it to people with complex 1 disease in particular. The version of it that's the most oldest and commonly used for lipids is niacin. Niacin's a terrible drug, meaning a lot of people get hot flashes on it and they won't take it. So what's good is having a drug nobody takes. There's other versions of it, and then we don't know how high to push the dose. There was a nice study in a small group of patients in Finland last year by our colleague, Dr. Vuorivaara Suomalainen, or Suomalainen Vuorivaara, and she did a really nice study in a very small group of patients with twinkle disease or mitochondrial DNA deletions. And in that very small subset of patients, they actually responded very nicely to kind of standard doses that you might use in just regular lipid disorders, so 500 to 1,000 milligrams a day. There were some side effects such as anemia, which are known. And of course, there's issues again about tolerability and how high should we go in children and so on. So one of the things that our group is doing is we'll soon, within a month, I think, or 2, have a clinical test to actually measure NAD levels in the blood. One of our biggest problems right now is we're blind. We don't know in whom there is or isn't a deficiency of this. It's not really a hormone, but of this chemical. So if we knew that it was deficient, it would make a lot of sense to try and replete it, and it would help us figure out how much to give to replete it. But like Dr. Tarnopolsky said, it makes good sense that we're treating it like a deficiency in this state, and that we should be trying to treat it. And a lot of our colleagues are trying to figure out how much to give and to whom, and the best version. It's certainly possible that not all Mito patients need this, and that only some do. Specifically, again, those where complex 1 isn't working like it should.
Okay. Dr. Koenig, I want to begin our portion where we're talking about questions for those who are living with mitochondrial disease. And a lot of questions surface around diet. So what are your recommendations when it comes to patients and their diets?
Yeah, I think Dr. Karaa mentioned it earlier. It's very important to have a healthy, well-balanced diet. There has not been a lot of evidence that this diet or that diet works in general for mitochondrial disease. There are a few specific exceptions. For example, patients with pyruvate dehydrogenase deficiency do well on a ketogenic diet. But these diets are for specific circumstances, and they should be monitored by a dietitian. So in general, I recommend to my patients that they follow a healthy, balanced diet. We do have a dietitian in our clinic that will sometimes meet with the patients to make sure they're getting adequate caloric intake. Sometimes we do recommend supplements depending on supplemental formula, things like Boost, depending on their weight and their ability to tolerate. We also frequently refer to gastroenterology. There's a lot of mitochondrial diseases where patients have difficulty gaining weight. And so those patients, there's really not a lot of good solutions. I'd be curious to hear if anybody else has a good solution. Some patients, again, if they just really can't eat, we do move to supplemental nutrition, either through Boost shakes, things like that, or through feeder tubes to try and maintain their weight. I've noticed over the years that underweight, undernutrition really does affect the overall mitochondrial function. Patients who move to better nutrition tend to feel much better. It improves their overall state of health. It improves their functionality. It improves their fatigue. It improves their muscle strength. On the opposite end, you have some patients who can't move well. And so they have a tendency to gain too much weight. And so in those patients, again, a nice, healthy, balanced diet, trying to encourage exercise and movement as much as you can is really the best thing to do. Again, recognizing there are some special conditions, which we can't go through all of them, that require special diets, but those need to be followed closely by a dietitian.
And I open that question to the panel. I mean, if you have any thoughts on that, because it seems like we get that question quite a bit.
Yeah, one of the things that we've published on with our muscle disease patients, which would be the same with mitochondrial patients, as Mary brought up, is that if you're not moving very much, you don't burn much energy. If you don't burn much energy, then you can't take in enough calories. Otherwise, you start gaining weight and become obese, which has its own issues with secondary mitochondrial dysfunction. And as a consequence, we found that about 90% of our MD patients were not meeting the US and Canadian guidelines for recommendations for just standard things like vitamin A, B, C, E, et cetera, et cetera. And so therefore, the only way to get the Canadian and US daily recommended intake was to supplement with a balanced multivitamin, which is available at Costco or any drugstore. So that's, I think, part of the reason why we were seeing so much deficiency is that people are smart. If you're not moving and you're burning 800 calories a day, you're just not going to have the repertoire of foods to provide you with the appropriate nutrients. And hence, I think that's why we saw these deficiencies. So identification and replacement is important. The other thing is that we found in many disease states that there's an increase in protein requirements. So on average, most people need 0.86 grams of protein per kilogram body mass per day, which is impossible to get if you're only eating 800 or 1,000 calories. And so it's important with a dietitian to make sure that people are getting about 1.2 grams of protein per kilogram body mass per day, just to deal with the increased turnover of skeletal muscle mass. And interestingly, work from one of my former postdocs, Stu Phillips, has shown also that the mitochondrial turnover, if it's accelerated, does increase protein requirements. And so we'd recommend about 1.2 grams per kilogram. Again, you can go to many public sites that are available on Google to punch in the diet and just take a look and see what your diet is like. But ideally, it would be best to do that with a trained professional, a dietitian or a nutritionist.
Go ahead, Amel.
I just wanted to add a comment about the diet for inpatients, because we talk a lot about diet for our outpatient when we see them in the clinic, and I concur with what Mary Kay and Dr. Tarnopolsky said. But when they get admitted to the hospital, a lot of the time the diet gets lost into the acute management of the patient. And I think that it's very important to explain or to have a letter with the patient that if they get admitted and we know that they are not going to be able to eat by mouth, that very quickly a dietary source for calories is initiated, whether by G-tube feeding or NG, nasogastric tube feeding, or TPN, because that's very important part of the healing process and making sure that the patient stays stable.
And I think I just want to add one more point about the gastrointestinal system often influences the diet. There are a lot of gastrointestinal dysmotility issues, which Mary Kay mentioned, but in particular, a lot of patients with PEO have difficulty swallowing, dysphagia, due to weakness of the oral pharynx. So we have to modify the diet accordingly and teach people to do a chin tuck so they don't aspirate when they swallow, and to take small bits of food alternating with sips of water. So those are some dietary modifications that should be made, and maybe even using a puree or soft diet when it gets severe. Similarly, the stomach can be affected by dysmotility. So people often have early satiety, which limits the amount that they can eat in a meal. So I tell people to graze during the day, meat, to eat during the day, have snacks to maintain their calorie intake. So just a couple of practical issues that I think we need to deal with.
Yeah, and I think, Michio, that brings up a really good point. Our patients should never fast. So fasting is so bad. It really is what we call catabolic stress. The body starts to break down things, and lots of things, chemicals get produced, and it's really a big risk for regression or progression or neurologic problems like stroke. So like Dr. Karaa said, when people are admitted, they really need to be fed, hydrated. The one issue that is interesting is that a lot of Mito patients can't burn fat very well. So like Dr. Tarnopolsky said, protein's really important, and carbs they can burn kind of extra well. And then there's a choice of what types of carbs, high glycemic carbs like candy, not so good. Low glycemic carbs like lentils, probably better. And so then the question is, what's the right mix, and how do people feel and function? So the fat itself, there's reasons related to NAD actually why you can't burn it as well as you'd like in your cells. And so when we think about what's the right diet, I agree with what everybody said. You need a healthy diet, but it might be over time we learn more what the ratio is of fat and protein and carbs and types of fat and so on, to help people function better, because it's not always intuitive to each of us, what makes our body run the best, what level, diesel versus high octane fuels we need. And so again, I think that's really an onus on the community. We really recognize that we need to understand more about nutrition, but in the meantime, I think all of this advice is very prudent, and please don't fast.
And while staying on the topic, Dr. Cohen, we're getting questions about vitamins, and one of the questions is, does mitochondrial disease affect absorption, and what levels should be monitored? So when you go to the doctor, can you get a test that will tell you what your vitamin levels are in your body?
So I would say back in 1990 to 1995, probably very few mitochondrial doctors supplemented vitamins more than I did. I used lots of vitamins in my practice, and now I probably use the fewest number of vitamins in my practice, compared to my colleagues. I agree with Dr. Tarnopolsky had said taking a multivitamin is certainly helpful unless you're eating a super healthy plant-based diet, which should give you most, but not all, of your vitamins, and that's where B12 comes in. So I think it's very individual. You can measure most vitamin levels in the bloodstream. I seldom do. There are cases where I would, like vitamin D needs to be measured routinely, especially if you live where I live in Northeast Ohio, where sunny days are 1 out of 3 at best. In my practice, I used to measure vitamin coenzyme Q10 levels. I don't do that anymore. After doing it for several years, I realized it didn't change my practice. So I put my patients through the expense of doing that. What I'm saying right now is probably highly controversial, and I hope it causes some debate among the discussants right now. But again, I measure vitamin D routinely. I measure iron and ferritin routinely, but I don't think I measure other vitamins or supplements routinely.
The only one that we also measure is vitamin B12. Just the consequences of B12 deficiency are profound. And we have patients coming in who only have B12 deficiency, who are spastic, demented, peripheral neuropathy. It's a horrible, horrible disease that people forget about. And you throw that on top of a patient with already pre-existent muscle or mitochondrial disease, and you're putting gasoline on a fire. And it's low-hanging fruit, inexpensive, easy to replace. Even if you've got pernicious anemia, you just use the sublingual form and it gets absorbed well.
Yeah, I agree. I also measure methylmalonic acid. I don't know if you think that's overkill.
Yeah, we did for a while, but didn't find it to be particularly helpful. I know that there are people that say that if your B12 is low normal in the blood, you're not identifying a tissue-specific B12 deficiency, but generally we just use a slightly higher level. So if 180 is your cutoff for B12, we say make sure everyone's over 225. And with that, we find that normalizes things because it costs us $50 for methylmalonic acid. And I think it's $8.90 for a B12 measurement. And we find keep it over 225, you're not going to see any tissue deficiency.
Thank you.
So a lot of patients are on, and I'll toss this to the panel, a lot of patients are on a Mito cocktail. Is that something that should be measured, and what are your thoughts on that?
You don't need to measure it at all. Bottom line is that there's very few that have undergone randomized double-blind crossover studies or parallel studies. And so, I think it's important that whatever people take, it is something that makes sense and has been studied in humans with bona fide mitochondrial disease. Of course, I'm biased. We did the first study using alpha-lipoic acid, CoQ10, creatine, and vitamin E, and showed 2 markers of oxidative stress were lower and lactate was lower. Of course, because those over-the-counter supplements, you're not going to get the kind of funding to do, a study for 2 or 3 years to show the effects on downstream. But it certainly is having a beneficial effect on the markers of mitochondrial dysfunction and is fairly well tolerated. I think it's important, though, not to chase everything that comes out or is suggested on YouTube, or there's a preclinical study that shows it, because you start adding more and more and more. And then I think people can get upset stomach, and then that limits their ability to eat normal, healthy foods. More is not necessarily better. And the other very important point, we did some studies a few years ago where we tried to throw everything in the kitchen sink at patients to suppress free radical production, to look at gene expression in a different context. And I was angry with my students and thinking that they screwed up on the analysis because we were seeing the complete opposite effect. But after many experiments, it was very clear that throwing in so many antioxidants, we made a pro-oxidant. So it did exactly the reverse. And so it's very important that you think you're adding one more and it's good for you, but the oxidative reductive pathways are very complicated. And so I would caution people to be throwing too much in, because you can completely flip it and make it dangerous for a person.
Yeah, so Cliff, if I can comment there. There's a lot of differences among all the Mito docs. I think the MMS, Dr. Parikh did a beautiful study several years back showing how variable it is. And so there is no one right answer. And Dr. Tarnopolsky kind of touched on why. One of the things, though, that I think has become really clear from Dr. Tarnopolsky's work and Dr. Greg Enz's work and others is that there's really too much free radical stress. And that's not great. But one of the things in particular, when you talk about what can you measure, there's a chemical in your blood called glutathione. It's your body's own antioxidant defense system. And it's sort of like Pac-Man eating up all the little dots, where the dots are the free radicals. And it turns out when we look, since now this is now a clinical test in America, a lot of our patients are glutathione deficient, either the total levels in their blood or the levels of the active form. There's reduced and oxidized forms, and they're very off. They're very abnormal. So now we utilize that, and there's a medication that provides an amino acid that helps you make more glutathione. I tell my patients it's like buying more lives in Pac-Man, and so it helps your body make more. And so we keep patients on vitamin E and lipoic, just like Dr. Tarnopolsky said, for reasons that they're very well tolerated, and they work sort of like a paper towel, soaking up the free radicals either in the cell or the mitochondria. And so again, while they're very well tolerated, they don't fix the glutathione problem. So glutathione is made up of 3 amino acids, and it gets kickstarted making more from something called cysteine. So we give patients, when we find low glutathione, N-acetylcysteine, and we find that it's been normalizing their levels. And so for us, we very carefully monitor glutathione levels. There's some caveats about how you get testing done, where you get testing done, how reliable the testing is if you have to ship it versus if you do it on site. So that said, I think it's something worthwhile to measure, because if somebody's glutathione level is normal, you probably wouldn't start them on a cysteine containing amino acid. But if they were low, then you can adjust the dose to normalize it. So I think that's certainly where our field wants to go, is to having better ways to know what we're monitoring. The other thing is, I think a lot of us measure leukocyte CoQ levels too. It's the white blood cell CoQ. And there's been some debate about, whether you measure blood CoQ or leukocyte CoQ and what type of CoQ you give somebody. But for many of us, we try to keep the leukocyte CoQ levels at the top normal to up to twice normal based upon some small publications and some laboratories that have released it. So about once a year, we check leukocyte CoQ and we try to make sure that our patients are not deficient for sure, and that if they're on it, that they're in the range that we want them to be. So I agree that we don't check many things, but we do check those.
The other point I'd like to make is with carnitine as well. I think there's no evidence to be giving people high levels of carnitine if their levels are totally normal. And certainly Ingrid Taine is one of the top people in the world in carnitine metabolism. And she would concur that, yes, measuring it, I think, makes sense, especially if someone's on a drug for seizures called valproic acid. Is absolutely critical. And that should not be given to those with Pol-G disease. But measuring and replacing deficiency makes sense, but huge doses and people running around smelling like fish with massive amounts of L-carnitine. There's no evidence, and people can correct me if they have a reference that I've not seen, that just giving mitochondrial patients CoQ10 in any way changes any metric of their functional capacity or biochemistry.
Mark, you don't mean CoQ10, you mean carnitine, right?
Oh, sorry, I meant L-carnitine. I'm so sorry. Yeah, yeah.
Just before a controversy broke out on that.
Yeah, and you know that of course we had a CoQ10 in our original study, right, and measured that it was being absorbed.
And I do think it's really important to emphasize what you just said, is that carnitine used to be very much in favor. And then there's been studies in the general population that it's not without risk over time for things like coronary artery disease. And it depends on whether you're a vegetarian or not. And, so I think all of us take carnitine a lot more seriously now and only give it, like Mark said, in certain instances where there's a deficiency.
And I want to stay on vitamins for a minute with Dr. Karaa. If a patient is planning for a surgery, are there any recommendations to help them get back to baseline post-surgery?
So I don't know of any special vitamin that we would give our patient post-surgery to make them recover better. However, I would say that there are certain precautions that we need to do prior to the surgery so that the recovery goes smoothly. And I would like to mention a few ones. Depending on the patient age, the patient's specific disease and organ system involved, what the procedure or the surgery is going to look like, and more specifically, the length of the surgery. So the length of time the patient is going to be under anesthesia. All of these are factors to consider when we are advising our patient and the surgical team of the pre-surgical precautions that we would recommend. And every patient with mitochondrial disease, I hope, has these surgical plans in place that they have discussed with their mito expert or treating physician. And so a few things need to happen when a mitochondrial disease patient is undergoing surgery. One, you've heard that fasting is not really good for a patient. And so we try really to schedule our patient as the first case in the morning so they don't have to fast for that long. And if they do have to fast, and if they have a history of not tolerating fasting well, then we do want to admit them to the hospital and give them hydration and calories through sugar water in the hospital before the surgery happens. We also want to make sure that before the surgery, they are pretty healthy. They are not having any acute sickness, or their vitamins and deficiencies have been repleted, and there is no acute issue that is going to worsen the reaction to the surgery, the anesthesia, and delay the recovery. Of course, this is not always possible when you have an acute surgery that is not planned, but at least making sure that the patient is well hydrated before the surgery, and making sure that during the surgery there's always some hydration and some calories that are being given to the patient, making sure that if the duration of the surgery is long, many hours, that certain types of medication are used carefully. Also, if the patient has muscle disease, the certain drugs that the anesthesiologists use need to be used with a lot of precaution, and some of them avoided. And then after the surgery ends, The issue is some of our patients take longer to recover from the anesthesia, so they might not be able to eat and drink and move properly right after the surgery. And so not discharging them right away like we do with other patients who undergo maybe day surgery. Really try to take your time, keep them in the hospital, observe them, keep hydrating them, and keep giving them calories until they are able to get back to their baseline of being able to feed themselves and drink by themselves. During that time, also, we have to be careful that we are not stressing some organ system. For example, the gut is very sensitive. And so if someone is undergoing a procedure or a surgery, they might get constipated. So we want to make sure that we treat the constipation, we preempt it from happening. And also, if they are on supplements, it's okay to stop those supplements before, during, and after the surgery until they are able to take them back by mouth. And as soon as they are able to, they should be resumed. I'm not sure if I'm forgetting anything else, but those are the major aspects of what needs to happen prior, during, and after the surgery so that the recovery can be optimized. And if I have forgotten anything, please, for the rest of the panel, to add anything.
Just one thing is, it depends on the surgery. So for example, if you're going in for knee replacement or hip replacement, which is common in the middle to older age group, there is good data that prehab, or what we call prehabilitation, is important. So, being followed by a physiotherapist to build up the strength in your muscles heading into that surgery helps with the recovery, because there's going to be an inevitable decline in function in a period where you're going to have to rehabilitate. We also did a study where we did muscle biopsies from people who were in their 50s who were undergoing joint replacement, and they had severe mitochondrial dysfunction. These are completely healthy individuals. So a person with mitochondrial disease and severe osteoarthritis coming in, you can imagine how poor their mitochondrial function is. Now, any surgery too, there's a possibility of blood loss. So it's critically important that if a ferritin is 8 or 4 or 10, that be replaced, and so that their ferritin stores are 50 or over going into it. Because if there's blood loss during the surgery, there's going to be a huge drain on those ferritin stores, and it's going to divert the ferritin into making new red blood cells and away from the respiratory complexes, which could further exacerbate the mitochondrial disease. So we always try to make sure hemoglobin's fine, ferritin's over 50, exercise coming into the surgery, if it's a joint replacement, for example, to keep those muscles strong and healthy. And again, optimal protein, and I like your point about the diet, because most of our patients have either mild to moderate, in some cases severe constipation, and that's just exacerbated in the post-operative period, especially if the abdominal contents are touched in any way, shape, or form.
Yeah, I want to agree with what you guys have said and add a little bit. So I used to say all my patients have to be admitted the day before for fluids, and they need to stay the day after for fluids. And I think that it really depends on the type of surgery. If someone's coming in for ear tubes and they're in and out and they're doing fine and they can just go home, they're eating and drinking well, that's fine. But I think that if someone comes in because they were in a car accident and they had some abdominal trauma, we need to be thinking about things like early TPN. We need to be thinking about things like early transfusion. A lot of times the surgeons will try to hold off, and maybe we can make it without a transfusion. These are not patients you want to wait until their crit drops to 20 before you transfuse them. We want to do early transfusions to keep their perfusion up and make their metabolic stress less. We want to do early TPN if they're not eating and drinking, so that we can get that protein back in them. And so I think just reassuring the surgeons that these patients are at a higher risk to decompensate, and maybe they do need to stay overnight if they have a longer procedure post-op. We're much more likely to keep our patients overnight after a procedure to make sure that they stay on fluids longer. This concept of, let's just cut their fluids off so that we can encourage them to drink. No, they don't get their fluid stopped until they're drinking. And so, I think just it's a concept of talking with the surgeons, and surgeons are their own special people, but talking with the surgeons to make sure they realize this is not their typical post-op patient, and that we don't need to be rushing them home. Maybe they do want to stay a little bit longer, and maybe we do want to help them recover a little bit better.
So I know we have got about 8 minutes left in this session, so I want to hit some more questions. So Dr. Hirano, one of the questions we received is, what's the best way to improve muscle energy, and muscle strength. Any thoughts on that?
I was muted, but I'll call on Mark afterwards because he's done a lot of work in this area. But the one thing that we know that seems to help most patients with mitochondrial myopathies is aerobic exercise. And bicycling is a good form of exercise, or swimming. So 30 minutes every other day it would be ideal. But I think that it works only, there's a window of opportunity to intervene in that way, because patients, when they're relatively early or mid-stage in their disease, will be able to exercise. But when they reach later stages, they'll be too exhausted by even 5 or 10 minutes, and they'll be sore for 2 or 3 days. And that may be counterproductive. So I think that exercise is a great form of therapy to improve physical conditioning, aerobic capacity, strength, and just overall quality of life. But I'll leave it now to Mark to comment.
And the only way to increase strength of muscle is exercise. There is no other way to increase it, unless you're severely deficient in something and then you replace it. But that's the only way to do it. And even people who have severe mitochondrial disease. So we've had patients who have what's called the VO2 max, under 10 milliliters per kilogram per minute. And to put that into context, as we sit here, we're at about 4 or 5 mils per kilogram per minute. And it's estimated that anything less than 12, people can't maintain independence in the community if you're an older adult. So people that severe, we were able to show that they could still lift weights, almost normal, because weightlifting is an anaerobic activity. Now, very important, however, there's so many caveats. One is, normally we can wait 2 minutes between repeating the same exercise for a healthy individual. With mitochondrial dysfunction, the ability to get your phosphocreatine stores back is massively delayed. So that's why maybe only 1 set to start with, because it may take you an hour to replenish that energy. And that's all you need. So start very, very, very low, gradually build up. Now, people say, oh, it's impossible because people are so impaired. But Tanya Tabasalo and others have shown that both with strength training and endurance exercise, anyone can do it. We just did a study in myotonic dystrophy where we had one woman who was so impaired, her feet were dropping. She was just like, skin and bones. She lasted 30 seconds on the bike when we started. At the end of 4 months of careful and very slow increases in her activity, we got her to 3 times a week, as Michio said, exercise, recover, 3 times a week for 30 minutes. She increased her muscle mass by 3 kilograms. Her fitness went up by 31%. That's her VO2, or the mitochondrial capacity, and her ability to climb stairs, get up and walk from a chair, get up from the floor, all improved significantly, as did her body composition and even her breathing. So we've seen this across older adults with mitochondrial dysfunction, myotonic dystrophy, and importantly, with primary mitochondrial disease. But every person is an individual. So you've got to listen to your body. And simple rules like always take a day off the next day when you're getting started to let your body recover, because that recovery will take longer. And if you push a little bit too much, as all of us have a tendency to do, listen to your body, cut it back, and do half as much the next time. But it's amazing what people can adapt to, even with severe mitochondrial disease. But don't overdo it. And if you have a cold or a flu or a fever, or you're just not feeling yourself, don't beat yourself up. Take that day off, and never work out if you're fasted for too long, as Marni's pointed out, or other metabolic stressors like fever, flu, vomiting, whatever. So make sure you're doing it on your good days, and on your bad days, just take a day off and recover. But we have innumerable tips and papers we published, and if anyone wants to reach out to us, we can provide that information to you, how to do it safely.
So moving along.
So sorry, Cliff, I just wanted to say one thing. I think Mark's guidance is so spot on, and it's been, inspirational to us and how we advise families. The one thing I would say is you want to really get a physical therapist involved with the family. A lot of this, again, isn't something people know how to do on their own. And if they go to the gym and get a trainer, they might push them too hard, not recognizing some of the limitations. So we're always encouraging our families to reach out to physical therapy to help them, especially ones familiar with mito disease.
Or a certified kinesiologist. So again, you need a certified professional. And in Canada and the US, you have to do a 4-year degree in kinesiology and then do a special certification. So it's that individual, because your average physiotherapy therapist may not know anything about exercise. So make sure that they are skilled in this area, and having certified kinesiologist and or a physiotherapist who understands it is important to help guide people through these specific nuances of exercise.
So, Dr. Falk, we've got about 2 minutes left, and I want to ask you, a question that came in was the risks of getting pregnant if you have mitochondrial disease and the concerns of passing that along to children.
Sure. So we don't know fully all the risks in mitochondrial disease in pregnancy. Dr. Hirano's group did a nice study, asking families. We review this, periodically. I think the issue is that there may be some risk in some patients of premature birth, of preeclampsia. There's some rare types of metabolic disease where there's something called HELP syndrome that doesn't seem that common in all mitochondrial diseases. Most mitochondrial diseases do not present prenatally. Sometimes there's a few types that might have some problems, like in pyruvate dehydrogenase deficiency, there might be some prenatal onset. Most families tell us they feel okay. We always get concerned though, during the pregnancy about the delivery and the stressors that a C-section or that a prolonged labor might have, and the issues about nutrition and anesthesia. So these are really important conversations for the Mito team to be having with the OBGYN team. And most of our families, I would hope, would be followed by high risk OBGYN. In terms of risk of passing it on, it depends if you know what the cause is. We're, again, over 300 different genes that cause mito disease in 2 genomes. So any genetic inheritance pattern is fair game. It could be a maternally inherited mitochondrial DNA disease, like something in the mitoDNA, a deletion or a point mutation, and those are passed on from the egg to the children. So very often they're brand new in the kid, but they could be in multiple eggs. So there might be a risk to their siblings. Sometimes it could be in the mother, but at a low level or with different symptoms or no symptoms. And so it becomes very important to know what it is to be able to understand the risk of passing it on. And so there's also, of course, nuclear genes, whether it's recessive or dominant or X-linked. And so, again, the idea is to figure out diagnosis before you ever become pregnant so that you can actually test either the pregnancy or even before you're actually aware you're pregnant. So even at the in vitro fertilization stage, if that's an option for some, or later by CVS or amnio in the 1st or 2nd trimester, you could actually test and understand the risks to the current embryo or fetus. So there's a lot of availability in America for nuclear gene variant testing if you know that it's disease causing and you know what you're looking for, meaning it's something running in the family. That's called pre-implantation genetic diagnosis. The issue of whether that exists for mitochondrial DNA disease is more controversial. It actually wasn't that good several years back. It's becoming better because the technologies for sequencing are becoming better. There's still not many places in America that will do it, but we've been creating partnerships with the United Kingdom. And the UK has a lot of experience, and some other European countries. Very nice, saying that it might be possible to do PGD from mitochondrial DNA disease. And so these are steps that we're taking to make it easier for families in America to get this done. But again, it all depends on knowing before you're pregnant what the likelihood is that a given variant does or doesn't cause a severe childhood disease. And whether or not you'd want to test for it. Does that answer your question?
Yes, thank you. And we are out of time for this Ask the Mito Doc session. We are all in awe of all of you and everything that all of you do for our patient families. And I just can't thank you enough for sharing your time and answering these questions from our patient families. And the time flew by so quick. I have questions that I'm sure will get answered for the patient families. And for those of you who are watching, we will take a short break and invite you to stay with us for our afternoon sessions.
Thank you.
We hope you'll stay with us for our next Mitochondrial Medicine 2021 session. You can choose Ask the Mito Doc for patient caregivers, or join us for coffee and conversation for the adult patient community, or you can visit Living with LHON. We'll be back after this short break.